welcome to my channel, and in this video I'm going to cover acute cholangitis. So let's start. So what is acute cholangitis? Acute cholangitis is an ascending infection due to biliary obstruction. Okay, so you have a biliary obstruction, a gallstone, all right, in the common bile duct, and this can result in buildup of bacteria, resulting in acute cholangitis. Okay, how does patient present? Patient presents with fever, jaundice, and right upper quadrant pain, typically known as the Charcot's triad. Charcot's triad is jaundice, right upper quadrant pain with fever. Now, uh, adding to the Charcot's triad, two additional features may result in a Reynolds pentad, which is known as hypotension or altered mental status. Okay, so the diagnosis for acute cholangitis is cholecystic liver function abnormalities, meaning imagine you have the stone lodged in here and you have your bilirubin coming from the from the hepatic duct, so that is building up here, and so there will be increase in the direct bilirubin, alkaline phosphatase, and mildly increased aminotransferases. And when you do a CT scan or an ultrasound, you see biliary dilation. Okay, so the treatment here would be antibiotic coverage of enteric bacteria, okay, especially E. coli, Enterococcus, Enterobacter, Klebsiella, and then drainage by ERCP within 24 to 48 hours is essential. Okay, so this bit of information is from UWorld. So this patient's presentation is consistent with sepsis due to acute cholangitis. So the biliary tract is typically sterile. However, biliary obstruction due to a gallstone, stenosis, or a tumor, or incompetence of the sphincter of Oddi due to previous sphincterectomy can disrupt normal bile flow mechanism and allow bacteria from the duodenum to ascend the biliary tract, causing infection. So it may present with the Charcot triad or may present as a Raynaud's pentad. Okay, labs will generally show a cholecystic pattern of liver function test with elevated bilirubin and alk phos, mildly elevated aminotransferases. Ultrasound is the best initial test, which will show a dilated common bile duct. Aggressive intravenous volume resuscitation should be administered. Blood cultures should be collected, followed immediately by empiric antibiotic therapy, covering broad spectrum antibiotics, enteric usually. So you'll start with piperacillin tazobactam or ciprofloxacin with metronidazole. Okay, and this is followed by an ERCP within 24 to 48 hours, because it's both diagnostic and therapeutic to help remove the obstructing stone. So as we said earlier, the best initial test is always a right upper quadrant ultrasound. MRCP is highly sensitive and may guide endoscopic versus surgical intervention. Okay, and the labs will show a high white blood cell count because of infection, high alk phos, high total bilirubin and direct bilirubin, mild increase in liver enzymes. Now, the diagnostic criteria for acute cholangitis is signs and symptoms of inflammation with fever and high white blood cell count, cholestasis, jaundice, and high alkaline phosphatase or bilirubin, and image findings showing biliary dilation and visualization of obstruction. Right, so the differential would be an acute cholecystitis. And in this case, remember that there is no stone or blockage of the bile duct. So there will be a normal or mildly elevated alkaline phosphatase, bilirubin, or there may be no jaundice at all. So this is how you distinguish acute cholecystitis from cholangitis. So the management approach in cholangitis is to treat the infection. Okay, you start with antibiotics and you do an ERCP. And a very high yield nugget is that patients will eventually undergo cholecystectomy as well. Okay, so you start with antibiotics, broad spectrum, such as cefazolin or ceftriaxone, but more specific is piperacillin tazobactam, ciprofloxacin with metronidazole. Okay, and then ERCP is indicated in all patients, and which can help in removal of the stone, stent placement, or sphincterectomy. Second line is indicated in case of failure of ERCP or if unable to perform ERCP. You would do a percutaneous drainage. The complications associated with cholangitis is abscess or a portal vein thrombosis. Okay, so an abscess around the liver, or it could be a portal vein thrombosis. So that's all for acute cholangitis. If you like the video, please subscribe to my channel and hit the like button. Thank you so much.